Hello and welcome to our online webinar with Andreas van Orten from Germany. My name is Holger Kast. I'm going to lead you through this webinar, and I'm the Global Training Education Manager for TRI, and I'm very excited for this nice topic, minimal invasive sinus floor elevation by using the TRI dental implant system in combination with the Jeder system. So before I pass the word to Andreas, I would like to take the chance and introduce you in our TRI philosophy and point out some topics of our tree performance concept. First of all, we are 100% Swiss-made implant system with the Swiss quality. So everything is made in Switzerland with a high quality aspect. The performance concept, I'm going to point out 2 points of it, of our 4 gold standards in the performance concept. Very important in the system is our simplicity. We are more or less 50% less components for all indications in your daily business. We have a really fair price, combining with other systems up to 50% less of price. And then there is the digital products, which we are having a really great portfolio for our digital workflows like CAD/CAM and guided surgery and so on. But today the topic is about sinus, minimal invasive sinus operation. So therefore I want to point out of our implant system the bone adapt, which you can see here. This is one important point of the system, and basically it describes the design of our implant. And so we have a tapered implant, which is for sure an important part for sinus operations. In the apex area, you see here a very radical thread design with a 45-degree angulation of threads, so to reach a high primer stability. In the middle part, you see the threads are going up all the part up to the top part of the implant, and the top part it's slightly flattened out the threads, but still there's enough thread design to reach a really great primer stability, which is really important for stable sinus operations and reaching a good primer stability. And then there's the soft tissue concept, which is a unique concept which we have, and you can see here we have a concave area outcoming of the implant. So this narrows out the abutment just above the bone level, and so we reach a lot of more space, as you can see in these X-rays. Maybe here on the right side down there, the X-rays can show you the tissue situation. So the tissue can surround the implant and protect the bone, the crestal bone, from the crestal bone stays really stable because the tissue can protect the bone really nicely. And with this soft tissue concept, we started a nice scientific with Andreas van Orten, and he's going to give us a small little view into this study, which is still ongoing. And then also a very important and unique product of our system is the so-called sinus cover screw. And you can see here on this picture, we have a special cover screw. If you have a sinus case where you don't know if you can reach enough primer stability, this cover screw is a little bit wider than the implant itself, and so it protects the implant actually to fall into the sinus cave. And then it's already on the time for me to pass the word to Andreas. Hello, Andreas. It's really nice to have you, and I'm going to have I think 45 minutes of great presentation and videos. And there's one thing more to say. If you have questions during the presentation of Andreas, please write those questions in your right side. There's a toolbar, and there you can write all your questions, and we're going to answer them after the first part of our webinar. And at the end, you have a chance to get answered the questions as well. And if we can't answer all the questions during this webinar, we're going to make sure to answer your questions later in an email from Andreas or us from TRI.
Hello, everybody, and thank you very much for joining us this afternoon. First of all, before we start the keynote, let me also say thank you, dear Tobias, for inviting me. It's really a pleasure. I would like to take the chance and say thank you to some of your team members too. Thank you, Valentina, Sandro, Raphael, Jessica, my colleagues at Zahnärzte Do 24, and as my special guest for today, my friend Dr. Pavel Krastev, who has actually invented the new VGO osteotome kit, which will be presented on the IDS next year by ZEP. Hi, Pavel, I want one. They are already sold out. I hope that you already had at least 3 cups of coffee and that you will enjoy the webinar. I'm actually working on a randomized clinical trial concerning the soft tissue concept of 3 dental implants, where I try to figure out the influence of the emergence profile. We analyze the influence of the abutment design mainly on the marginal bone loss within the first 12 months after the prosthetic treatment of the implant. Furthermore, we try to gather information of the influence of the abutment design, and we try to figure out if whether a concave 3 dental implants design or a convex standard abutment design is superior on clinical parameters like the plug index, the gingival index, and the probing depth. For me, this is really an exciting task, and I can't wait to see the results, but I have to be very, very patient because we need a lot of examinations, and we decided to have at least a 12-month follow-up. I could talk about this trial for hours, but let me get back to our main topic. We worked hard to provide the best sound and picture quality for you. So today you will see a combination of slides and videos combined with a green screen technology. During this first part in full screen presentation, please feel free to send us all your questions concerning the Jeder system, and we will try to answer most of them directly after this first part before we start to stream another video of a minimally invasive sinus floor elevation utilizing the Jeder system, which we are going to comment at the same time live. Enjoy. The minimally invasive sinus floor elevation utilizing the Jeder system. The Jeder system was invented in Vienna, and I am an enthusiastic user since 6 years now. I am very interested in 3D template guided surgery and the prefabrication of prosthodontics too. And sometimes people ask me if it is really necessary to use these techniques in common treatment cases. Well, if you ask me, I would say yes, because the benefit for our patients is enormous. Let me just show you a typical case. In the region of the right upper molar, we only had a residual crestal bone height of 1 mm, and in the region of the second premolar 4 to 5 mm, which is, as far as the ITI treatment guide is concerned, a typical indication for a lateral window technique. When you take a look at the postoperative X-ray with the knowledge in mind that we had chosen a Crestal approach, it is sometimes surprising for some people to achieve such an elevation without the necessity of a lateral window. What interests me most when I follow up with new surgical techniques is what are the main benefits for our patients. For example, less pain and a shorter period of time of inability to work. If you choose a classical approach for sinus floor elevations, the average length of inability to work is 5 working days. The decrease of the days of inability to work is enormous when you choose a minimally invasive Crestal approach to an average of 1/5 of a day, which was investigated by Philipp Jesch in Vienna in 2013. This is an effect that I can confirm from my own experience. Did other authors come to similar results? Let us look at further scientific research. You will find evidence for the benefits of minimally invasive or flapless surgery in scientific databases like PubMed or Web of Science. Taking into account the time that we have today, I have chosen one paper by Fortin et al., which was published in 2006. The main aspects in this paper on the effect of flapless surgery on pain are the following. You will find a higher number of patients who felt no pain at all. The overall number of painkillers taken by patients is lower. The number of tablets taken decreased in the group of minimally invasive surgery patients much faster compared to a classical approach. When it comes to the question which minimally invasive sinus floor elevation technique should be preferred, you are really spoiled for choice. There are so many techniques, we could talk about it for a week or two. I've tried most of these techniques and some of them are still in my repertoire. When you try to categorize them, you will find osteotome techniques, techniques utilizing special drills and burrs, piezo surgery techniques, etc. I find it so interesting that I am working on a systematic review at the moment, and I hope to finish it at the beginning of next year. Again, just as a matter of time, I will concentrate on my personal favorite technique, which allows to solve nearly every sinus floor elevation successfully. It is called the Jeder System, and I would like to provide some impressions of this technique for you. Enjoy! These are just some impressions of clinical aspects through my microscope. We will talk later about the details, but as you can see, it is possible to get access to the sinus floor flapless. Or with a classical approach with a flap design. The inventor of this technique is unfortunately not me. It is Dr. Klaus Eder from Vienna. Klaus is a lovely, nice guy, and I was able to have a look at the system and at this technique in Klaus' own dental practice in Vienna at the beginning of the decade for a week. Dr. Philipp Jesch is the co-developer and one of the heaviest users of our Jeder community. Klaus' daughter, Professor Dr. Michaela Bayerle-Eder, is the CEO and the coordinator of research activities of the Jeder company. And if you need help or if you have further questions, please get in contact to Rainer Bandorf, who is also the contact person for first surgery support for new users of the system. Let us now have a look at the hardware. The main component for me is the display with the pressure control unit. And the main principle is to perforate the cortical sinus floor, without damaging the Schneiderian membrane. In most of the times we can maintain a water pressure of 1.2 to 1.5 bar in our pressure chamber, in which we insert the special Jeder drill. To maintain the pressure and to pump further amounts of sterile saline solution into the sinus, we use a motor-driven syringe, which you can see here. The whole system contains a pressure control device and a mechanical device for vibration to detach the Schneiderian membrane. The motor-driven syringe is controlled by a foot pedal. And last but not least, let us have a look at the handpiece and the Jeder guide with the pressure chamber. This is a part which has developed evolutionary over the years. The next step is a one-piece combination, which is the current object of research. Let us now have a look at the surgical approach and the protocol. On the photo on the left-hand side, you can see the so-called ATP punch, which stands for atraumatic tissue punch. The ATP punch was developed by Professor Jesch, Dr. Philip Jesch's father. Here you can see an intraoperative aspect of the flapless approach. For those who prefer a classic approach, maybe in connection with any augmentative steps, for example bone augmentation or connective tissue grafts, or for those who prefer a better overview of the surgical site, it is also possible to have a classical approach with a flap. As you can see here, where I grafted a connective tissue additional to the sinus floor elevation. The first step is the pilot drilling. In this case with a 2 mm drill close to the sinus floor without penetrating it. Our aim is to get as close to the sinus floor as 1 to 2 mm. On this photograph you can see the Jeder guide with a clear silicon sealing element which maintains the tightness of the pressure chamber against the soft tissue or the osseous structures when performing a flap procedure. This is a picture of the Jeder drill before it is inserted into the pressure chamber. I've prepared a video sequence to demonstrate the whole procedure for you. I marked the surgical site with the ATP punch through a 3D surgical guide. I take my time to remove my tissue punches properly because I often use them after the augmentation, as a graft on the buccal side, or set them back after the augmentation. I use an adapter sleeve to reduce the drilling diameter to 2 mm. For the pilot drilling, which you can see now. Right now you can see another component which maintains the tightness of the pressure chamber. The Jeder system is really flexible. This is again the Jeder drill, and it takes a moment. Now we start to pump saline solution into the pressure chamber. We wait until 1.2 bar is reached and then I start drilling in a tapping mode. In the small picture you can see the pressure control device and the decrease of pressure when we opened the cortical sinus floor in an extension of maybe a pinpoint. Then you have to stop drilling immediately. I would like to repeat this final sequence once again. Wait until at least 1.2 bar is reached. Start drilling in a tapping mode and stop immediately when pressure decreases. Which is right now. That's it. The next step is the lifting of the membrane. I remove the drill, close the pressure chamber with my finger and start pumping again. I take my time to let the pressure and the oscillating water column detach the Schneiderian membrane till I reach my prior determined volume. Which you can see in the video right now. Afterwards, I enlarge my tiny tin point perforation with a round diamond burr. Or for those who prefer piezo surgery, with a round tip. The membrane is still elevated at this moment. And then I pump back the saline solution out of the sinus. And you can see there are no air bubbles or anything like that in the hose. Augmentation is a topic which we could talk about for at least a weekend. In this case, I grafted with a bovine bone substitute material, which is often a little bit time-consuming through the small approach. So it is worth to take a look at proper alternatives, but we will get to this point in a minute. And finally, the implant placement. If it is possible to have a one-stage surgical protocol, place your implants right now. And here you can see a tridental implant and the tripod. Always looks very fancy. And here's the implant. Let us now take a second look at the augmentation alternatives. In the literature you can find evidence that if you can maintain the space, for example with an implant, a blood clot still itself can be enough for proper bone formation. What I often use as a bone substitute are APIF membranes when I can ensure that the implant is maintaining the necessary space. I learned this technique from Dr. Joseph Chocroun in Nice, and I recommend his courses together with two great surgeons, Jérôme Sommignon and Alain Sion-Prairie, a lot. It had been a very inspiring weekend in southern France for me. By just drawing some venous blood and using an easy-to-learn protocol, you will be able to produce your own bone substitute material for one-stage surgical sinus floor elevation procedures. In the video right now you can see a so-called big membrane. And smaller typical APIF membranes, which I often use as a graft or two. Lovely technique. When it is necessary to perform a two-stage procedure, you can use PRFs to build a so-called sticky bone instead of using pure granules, which is a huge handling advance in my eyes. Let's have a look at the surgical tabletop. I'm sure anyone will agree that it is more comfortable to handle a putty sticky mixture than a handful of granules. For those who do not like to draw blood or who do not like to invest in a new technology, it is worth to consider the use of cross-linked hyaluronic acids in one-stage sinus floor elevation procedures. It is really easy to apply, it has an antibacterial effect, and it is quite cost-effective. And here you can see the easy handling. It's very fast, very safe. For those who like xenogenic collagenated cortical cancellous granules, I've made a video of another product which is very easy to handle in combination with minimally invasive sinus floor elevation. And you can use it with a syringe. It's very fast, it's very safe. And I personally made good experience with this bone augmentation substitute material. Let us now have a look at some clinical cases. The first case I would like to present to you is a healthy best ager who demands the best functionality and better hygiene conditions in comparison to a dental bridge which had to be removed. I suppose that everyone agrees that this situation could have been restorated conventionally, but he decided to go for a single tooth restoration with implants, so that I had to deal with a lack of bone, especially in the first molar region. This need for augmentation is typically solved by a lateral window technique normally. Due to the self-employment of this patient and his wish for minimally invasive surgery with the aim of a minimum loss of working hours, we decided to lift with the Jeder system from 1 to 12 millimeters in the molar region and from 4 to 12 millimeters in the premolar region. Here you can see the transverse slice of the CBCT in the region of the right upper molar before surgery. This is a clinical aspect of the right side, and as you can see, we had to deal with some minor other problems like loose fillings and crowns to caries, and we did all of this simultaneously with the implant therapy. This is the postoperative panorex. At that time I often grafted with a bovine bone substitute material, which is very radiopaque. So in my older X-ray pictures, the graft is much better visible in comparison to PRF, hyaluronic acid or allografts. That is one reason why I like to show this picture, and the other reason is of course it was very successful. To be absolutely honest, I do not know any other technique to lift from 1 to 12, 13, 40 millimeters with such a fast learning curve and so much predictability for the patient as the Jeder system. This is a post-operative clinical aspect. I grafted an epithelial connective tissue punch to thicken the soft tissue and sutured a collagen fleece onto the donor side. The implant side of the premolar region was left for open granulation. This is the post-operative X-ray of the implantation, which took place 9 months later. And the following X-ray shows the site after prosthodontic restoration. And as you can see, we changed our prosthodontic protocol to screw-retained restorations in comparison to the older restorations, which was an individual abutment and on top a cemented crown. I would have loved to graft another connective tissue for the buccal aspect from the canine to the molars, but my patient asked me for some patience because of his workload. And I'm still waiting for some years now. Keep fingers crossed for me, because I love to graft. And last but not least, the occlusal aspect and the portrait 15 minutes after surgery. The second case shows another sinus floor elevation with the need of a huge amount of graft because of the lack of vertical bone. I have to get back. If we would have performed a lateral window technique, the septum would have been a structure of interest. When you perform a Jeder sinus floor elevation, it is really not a challenge at all. You will have a very steep flank, which is very useful, as you can see here. The graft is allogenic and mixed with IPRF, also known as sticky bone, and we will perform another vertical and horizontal guided bone regeneration on the Crestal side with a plate from the FAST system. Again, the team around Dr. Shokun, but this is another topic. The third case is very similar to the second one, but I would like to give you an impression of the capability of the system. As you can see, this is typically not an indication for a Crestal sinus floor elevation. But it is also possible to graft even large volumes if necessary. In this case, just like in the case before, we grafted allogenic bone plus PRF, again the so-called sticky bone. Case number 4 shows a simultaneous implantation and sinus floor elevation. This is the preoperative X-ray, and this is the postoperative panorex. The following case is quite similar as the one before. You can see a lack of vertical, I was too fast. You can see a lack of vertical bone height in the cone beam computer tomography, and we solved it with a Jeder sinus floor elevation at 2 places at the same time. As you can see on the post-operative X-ray. And here the radiographic control after the prosthodontic restoration. But I'll get back to the postoperative X-ray. Okay. Finally, and because I love symmetry, I would like to present to you a similar case on the left side. This is a preoperative cone beam computer tomography with a nice septum between the first and the second molar region, and the postoperative X-ray. The graft in this case is again allogenic sticky bone, and the X-ray after prosthodontic restoration. If I could awake your interest for this technique, please visit our new YouTube channel Zahnärzte do 24. I would really appreciate your subscription. We will post more and more topics, lectures, video blogs and live surgeries within the next month. Let me say thank you very much for joining us and taking the time. If you have any questions, please feel free to email me. Andreas at zahnärzte-do24.de. Andreas at zahnärzte-do24.de. Thank you.
Okay. Thank you, Andreas, for this first part. We have now time for some questions and answers. Let me get back with my camera as well. Okay, hello. So, Andreas, we have a few very interesting questions from all over the world. Let me start with the first question from Dr. Silvio Serio from Argentina. He's asking, how often does perforations of the sinus membrane occur?
When you have a look at PubMed, you will easily find the investigation from Philip Jesch, which I mentioned in the lecture before. This paper was published in 2013. It's a case series with 20 patients and a follow-up of, I think, 1.5 or 2 years. And in this case series, microperforations occurred in 5% of the cases. After my personal experience, the number of perforations is much lower in comparison to a lateral window technique. If you have to deal with a perforation, you can close your minimally access and just get back after maybe 3 months or even later, or you can perform a lateral window technique. I would recommend not to try to inject more than 2 milliliters at each site and try to be very careful when you extend your first pinpoint perforation. And please be careful during augmentation with the granulous material.
Okay, then there's a next question from Dr. Kumpula from Finland. How long do you wait in a 2-stage procedure before the implantation?
Okay, it depends on the volume and type of bone substitute material and whether you can achieve a good primary stability of your implant. For example, the tridental implant can often provide a very good primary stability, and whenever it is safe and predictable, I try to follow a 1-stage procedure to reduce the overall time of the treatment.
Okay. And then there's a next question actually from Italy, from Dr. Loreto. Is immediate loading an option in combination with the Jeder system?
This question goes a little bit in the same direction as the question before, I think. Whenever it is safe and predictable, I try to shorten the overall treatment time for the patient. I use a surgical motor which monitors my torque, and I love to use the ISQ system. When my torque is above, let's say, 35 Newton centimeters and my ISQ value is above 70, I start to think about immediate loading. But at the end of the day, I discuss it in every case with my patient, and they often rely and choose a more conservative and safe protocol because most of the Jeder lifts are in the molar region, and a fast aesthetic solution does not stand in the foreground for most of my patients.
Okay, then there's one question. What's the torque you reach in an extreme case from Dr. Royce in Germany? Like, yeah.
On the one hand, I try not to have a torque which is over 70 Newton centimeter, because you can heat the bone. And as far as the Crestal ridge side is concerned, I try not to go beyond 35. And in the Spongiosa, let's say up to 70, but very carefully, very slowly. On the other side, when I have a very loose implant, it depends a little bit on the situation in the mouth, the clinical situations. Can I close my flap? Can I assure that there won't be any occlusal contacts in the future, which could make a problem for the implant. I would say, on the one hand, as far as the Crestal ridge is concerned, 30 to 35. Otherwise, you can overheat the bone. In the Spongiosa, I try not to exceed 70 Newton centimeter of torque, and at least I would have, let's say, 5 Newton centimeter, which you do with your hand. Otherwise, I prefer a two-stage procedure.
Okay, and then there's like two questions. I think I can combine them, and I think we have to go on after these questions. And as I told you, we're going to answer all your questions afterwards. We have them all written down here. But these last two questions, which I think are very interesting, they come from Dr. Klaus from Switzerland, actually, and he's asking, where can I learn this technique, and can I bring a patient, for example, to your office and learn the technique maybe in combination with somebody? And that's maybe two questions you can answer in once.
Yeah, we often have workshops in Germany and Austria. You can find some of them on our homepage, zahnärzte-do24.de, or at jedersystem.com. But you can just also email me, and I will get back to you. And taking a patient into our office or into our practice, yeah, sometimes this is an option for colleagues which used to attend our workshops, and they often bring a patient for the very first time, and we cooperate. Or if they want to have a second look at this technique, I do the sinus lift part, and the colleague makes the implantation. So no problem. Whenever you're really interested, you can email me, you can phone me, you can get into contact personally. I live nearby Dortmund. We've got a nice airport 50 minutes away. So whatever you want, just email me, and I'm really looking forward to get in contact to you.
Okay, I think, Andreas, we have to go ahead with our with your presentation. Now, the second part is a live surgery, actually, a video of a live surgery, and Andreas is going to explain all the steps live here. And as before, please write down your questions to this. We have another short question and answer after this video of the live surgery, the TRI implant. And I'm going to start the video, and yeah, we come back after this video for you guys.
Right now, you can see the CBCT of a male healthy best ager. We had to remove teeth number 27, respectively number 15, and therefore plan to work with implants in the region 2.4 and 2.6, respectively number 12 and 14 for a screwed bridge. Due to a lack of vertical bone, we decided to work in a two-stage procedure. As you can see, there's an old residual root in between, which does not matter, and there are two septums. And even my colleagues who are specialized in endodontic techniques and tooth preservations preferred the surgical approach. The quality of the older restorations and the soft tissue situation is not perfect, but due to the time which is needed for the graft to mature, we decided to start early with the sinus floor elevation right after a short hygienic period. In cases in which I do not work with autologous bone, I like to combine my bone substitute materials with PRF preparations, as you could see in part 1. At the beginning of this sequence, you can see the vein light, which is really helpful to find veins. Right now, we are just drawing some blood and collect it in so-called vacuoles. The next sequence is going to be presented to you with a time lapse in quick motion, just to give you a short impression. And we are starting the time lapse right now. You can see different PRF preparations like APRF membranes and PRF liquids. And you can never have enough. In real time, it's not that fast. It takes, let's say, 10 minutes. Right now, you can see the ATP punch. I clean my surgical site very carefully because I must not lose my tightness of my pressure chamber due to a compromised soft tissue situation. So just be a little bit careful. Because of the very thin cortical sinus floor, I decided not to perform a pilot drilling, but I started directly with the Jeder drill, which you can see here. You will always have to wait for an adequate water pressure before you start drilling. Yeah, I always drill in a tapping mode. And as soon as the pressure declines, you have to stop drilling. So this is a moment, just stop, relax, remove the Jeder drill. Then I close the pressure chamber with my fingers instead. And I start to pump my calculated amount of saline solution into the sinus to release the Schneiderian membrane. The release is supported by the vibrating water column, which is being provided by the Jeder system. Afterwards, enlarge your tiny pinpoint perforation with a round diamond burr. The membrane should be still elevated at this moment. Then it's time to pump back the saline solution, which gives you another opportunity to prove the structural integrity of the Schneiderian membrane. In cases of larger perforations, it is likely to occur that you will see air bubbles instead of saline solution. It is also reasonable to perform a Valsalva maneuver by pinching one's nose shut while softly trying to press air out of the nose, but please softly. Here you can see the APRF membranes. For those who do not like to draw blood, it is a very good alternative to use a collagen membrane, just as a protection layer. Afterwards, I started to graft. In this case, the patient preferred cyanogenic bovine bone substitute material, which was applied by this blue carrier. After grafting, we had to close our surgical site because of the need of a two-stage procedure. There are different methods, but I often used a soft tissue crunch from the pellet, which I start to fix with a crossed suture and afterwards with interrupted sutures. We often care for the donor side with another APRF membrane or a collagen fleece. I fix it with another crossed suture and some drops of histoacrylic glue. This is a histoacrylic glue. Just a drop, just like in free gingival grafts. Even without a graft with histoacrylic glue is possible. And finally, I would like to show to you the pre-operative panorex, which is followed by the post-operative panorex. I'm sure that everyone will agree that we will have an easy implantation after the wound healing and after the maturation of the graft. Thank you for watching and taking the time. I appreciate it a lot.
Yeah, thank you, Andreas, for this great video of this live surgery.
You're welcome.
There is only one little question. There was one question about the TRI system. If you, how do you like the TRI system for this type of sinus operations?
To be absolutely honest, I've chosen the TRI system because of its abilities to perform even in these really difficult situations in sinus floor elevation procedures. And as far as the ITI treatment guide is concerned, you should not perform a one-stage procedure if you've got less than 4 or 5 millimeters of residual bone. And I hope no one will put me into jail after I broadcast this live. But I even have performed one-stage procedures with less than 4 millimeters of bone. And then you really need a very aggressive, sophisticated shape design that will easily achieve a high amount of a high torque and a high ISQ value, because otherwise everyone will bring you into big problems when you do not succeed and when you perform one-stage procedures with less than, let's say, 5 or 4 millimeters of residual bone.
Okay. So I think we have some more questions, but I would like to take the chance and have also a few slides to see what happens with TRI and in the future, or better, what courses and conferences that you can meet us. And that's why I would say all the further questions we're going to answer later on. And I would like to say a really big thank you to Andreas for this really interesting presentation, and yeah, for giving us good knowledge about the Jeder system and so far. Thank you very much, Andreas.
My pleasure. Thank you.
Thank you. Okay. So I take just a quick time to announce that we're going to be at the ERO in Vienna from the 11th to the 13th October. You can come and visit us and join us and see for sure really nice new products. We're going to have some very interesting stuff on our stage going on our booth going on. And also we have like a happy hour time, so come pass by and see what nice products we're going to launch there at the ERO. Then we have still some few seats left for a very interesting course, which it's already the 4th or 5th time. It's always updated and it's always busy, and there's like a few seats left for our advanced all-on TRI course, which takes place in Zurich this time in combination with a production site visit. It's going to take place on the 13th to 14th December this year. Feel free to contact us and be a part of this exciting course with Dr. Luis Bessa from Portugal. And then there's already in the next year, we're looking forward to being on the TRI Symposium in Australia. Really great place. I've seen it already last year. It's a beautiful place where we're going to do it, and it's going to be with Dr. Mario Steigmann and Dr. Homlei Wang, the art and science of implant therapy. And those both guys, they are both on the stage, and they explain their different ways of implant therapy. It's going to be for sure a very interesting 2 days course. So if you are interested, please contact us at any time. And then there is also the important thing in March going on in 2019. The 3 days course, which we always do in the university in Zurich. It's also in combination with a production site visit, and it's going to be with Professor Dr. Homlei Wang and Dr. Ronald Jung. Please contact us for these courses. And so then I only want to give you the next date for the next webinar with Dr. Joel Teles from Portugal. It's going to be on November 14th this year. So we have an interesting topic coming up there as well. More information is coming soon. And then this is a very nice thing to announce. We have new the TRI Academy community on Facebook. So if you like, please take a look at our community on Facebook. It's a group of all TRI members which can discuss and share their nice cases. And for example, we had once a really nice case shared by a Portuguese doctor, and so we decided to announce this case then on our website and so on, and all social medias we could, because the case was really nice. So feel free, share your cases, share your x-rays and things with us on the TRI Academy community. And then it's also on the time for me to say thank you for listening. I hope you enjoyed this webinar with Andreas van Orten from Germany, and I say thank you for listening, and see you soon anywhere in this world. Bye.
Bye.